Today I'm interviewing Professor Judy Lewis, who is Professor Emeritus in the Department of Public Health Sciences, and we're going to have a conversation about her life and career. Good afternoon, Judy. I think it's afternoon. Good to see you, and welcome back to visit the department and do this interview. Really glad to have you here. Maybe you could start by just telling us a little bit about where you came from that was relevant to where you ended up and what you did in your career.
Well, first of all, thank you for having me here. It's an honor to be interviewed. This department is near and dear to my heart. And I really respect everything you've done since you've been here to help make this a better department. So thank you. So my story is one of journeying east, and I saw the map for the department, and I think we're missing my trajectory because I was born in Bellingham, Washington, and then moved to Iowa when I was 6 months old, and then moved to Illinois, and then moved to Connecticut, and I've been here ever since. So my academic trajectory began, I would say, in elementary school with a good public education, which I wish more people had access to these days. I come from a working class family. My father's father was a coal miner. And that was my family in Washington State. They were all coal miners. And I thought if I ever wrote an autobiography, it would be the coal miner's granddaughter, not the coal miner's daughter.
Right.
My father never graduated from high school because he had to go to work during the Depression. My mother had a high school degree, and my father was a bus driver, and then he worked for the post office, and then he became a big labor union organizer. So I grew up in a very labor-friendly family in Iowa in the 50s, which was not a very popular time for unions in Iowa. And so in high school, I knew I was kind of interested in health, but at that point in time, girls were told things like, well, you could be a medical technologist. But I did a lot of science projects, and I went to the University of Iowa as a liberal arts major. I mean, nothing particular. I took a zoology course that pretty much finished my idea of medical, and chemistry, organic chemistry. Those were both pretty challenging. But I had the good fortune, first of all, I want to say I had the good fortune of going to the University of Iowa on a full ride scholarship. James Rosenfeld, who was in the class ahead of me at my high school, died in a car accident, and his family provided a full ride scholarship.
Wow. And
I was the first recipient of that, and made a huge difference in my life. So I was in the honors program. I was very well connected. I could take pretty much any professor I wanted, and we had some pretty high level people at Iowa at that time. And so I had a very good undergraduate experience. And I've always been involved in a lot of organizations. And so in high school, that was true. In high school, I could only be the secretary of the senior class because that was the girls' position. So I was at Iowa from 64 to 68, which was a pretty turbulent time. And anyway, I became the class president when I graduated from the University of Iowa. So that was how rapidly things changed in terms of what women could do. I was interested in education from an early standpoint, so I was on a committee as an undergraduate about evaluating education and teachers. So I think it's kind of interesting that kind of started then in terms of thinking about how to be more effective with education. And I did research. I got my degree in sociology and psychology, but I was very much a symbolic interactionist type of sociologist, which is looking at both sides of how I present myself and how others perceive me. So my work then was on self-concept and self-esteem. And then I went to the University of Illinois, but I went to the University of Illinois as a faculty wife. I got married after graduation. And because I was married to a member of the faculty, I could not get any scholarships or even a teaching assistantship. So I took some courses there, and then I ended up working for a year for the Department of Mental Health in Illinois. And that was at a time of deinstitutionalizing mental patients. And that was a formative educational experience for me. So as a college graduate, I was expected to keep these people out of the state hospital. Now, I had no clinical training, and I had energy.
Right.
But I learned a lot from every single person I worked with. And that was the beginning of my learning that you can't do anything without knowing people first. I also learned that I didn't want to take care of patients one-on-one or people one-on-one. I wanted to fix systems. And it was also my first experience working with using data to inform public health work. So we were kind of trying to track what people were doing and how they were doing it, and provide immediate feedback, because collecting information and never giving it back can get really bad information. So that was a really important time. Meantime, we decided we were going to go someplace where I could have a fellowship, and my husband could do more active sociology. And the place ended up being Connecticut. I got a medical sociology NIH fellowship at Yale and so that was another wonderful opportunity that I was given. So at that time, medical sociology was all about boys in white, right? Because doctors were men, and it was focused on doctors.
So what you mean by boys in white is that the people who were thinking and delivering were white-coated male doctors. Is that what you
Yes, and the people of study, if you were in if you were medical sociology. So I don't know I've been calling myself a public health sociologist for a long time now, because medical is not what attracted me to this. Right. People and populations is what attracted me to this career. And so when I was getting ready to finish my degree, the only job opportunities in Connecticut were teaching intro sociology, which I had absolutely no interest in. And then an opportunity came up here. So this school was just getting started, and there was a research project looking at how to...
So this was UConn Health was just getting started?
The school was just getting started.
Okay.
So this was 1973.
I was going to ask you what year?
So that's 52 years this fall that I've been here.
Wow.
So I moved and stayed. And I guess the first thing I'd like to say is that I've had the opportunity to grow here in many, many ways. And because I work in communities, you can't just keep moving around all the time. You know that. You work in communities. It takes a long time to develop trust and relationships. So I've spent my whole life here ever since I came.
So I'm sort of curious. You've intimated that at that time it was hard for women to break into this, but somehow do you feel like there was an opening here that didn't exist elsewhere, or were you just lucky, or there was an individual, or what was it that gave you the opportunity here when it was so closed in many places?
Well, it was still closed here. I was one of 5 women faculty when I came.
Okay.
So,
all right.
I will tell you, I watched Steve Schenzel's discussion with you, and I was really struck by his theme of mentoring.
Yeah.
It made me realize how much I lacked that after I left undergraduates. Because even then when I came here, I had mentors, but it wasn't quite the same. But I did work with 2 very talented people when I came here, and I was running the research project. They were the ones who got the grant, and it was really something ahead of its time to be trying to measure quality of care. And of course, physicians wouldn't let you look at what they were doing. So we worked with nurse practitioners who were just getting started because they were more open. Yeah. So I learned more about pediatric primary care conditions at that point in time than I'd ever thought I would learn in my life. And And I got to travel all over Connecticut and Massachusetts, where there were nurse practitioners who would let us come into their
Now,
practice.
this department didn't exist at that time. You were.
I was in the Department of Behavioral Sciences in the dental school,
Okay.
as well as primarily in pediatrics.
Okay.
And that was the case from 73 to 79. And then I came into the community, as it was called then, the community medicine department. And so the grant ended. It was a 2-year grant. But we started working on a grant to create school-based health clinics in Hartford. And that was funded in 1975. And for 7 years, I directed that project.
Wow.
And it is probably the thing I'm most proud of in terms of what I've accomplished in my entire career, because it still provides services to kids in Hartford, which remains one of the most low-income community, small capital cities in the country. And so it was a really special time. It was hard work. We had to build a clinic. Nobody taught me anything about constructing clinics in graduate school. We had to fight with resistance. We had to learn the language of education. I hadn't been in an elementary school since I was a child. Communicating between health and education, dealing with the state legislature to get legislation changed to make nurse practitioners in schools acceptable. But it was a very, very exciting time.
So that was, I think, shortly after the first community health centers started to get established in the U.S. Is that correct? In my old department at Tufts,
it was about the same time these things were happening. But community health centers, I think, started a little earlier.
That's my memory.
This was a Robert Wood Johnson Foundation initiative, and so we had schools. We had a comparison school and a project school in Hartford at Mary Hooker School, and we had the same in Bloomfield. Nobody seemed to care that much about Hartford, but Bloomfield couldn't make it because we were interfering with private pediatric practice. But we learned so much. I mean, I learned so much from working in Charter Oak Terrace, the same group that Steve worked with, just in terms of how you can communicate. I mean, and how you could provide clinical care to kids without their parents being present, and how to make them involved. So we had a wonderful dentist, Alan Hinden, who wouldn't treat a child until they were ready, no matter if they had parent consent or not. And these kids never had dental care. And if the child wanted to be treated standing up by the door so they could leave, he would do that or he would have them bring a friend, and the friend would be the support. Very unusual stuff to happen in this school. And so that was fabulous. That program grew. Of course, we started with elementary students because we didn't have to deal with sexuality as much, which becomes another issue. But it did expand to middle and high schools, and it still continues. So that program has served hundreds of thousands of Hartford kids.
Well, that's a beautiful story. And then, so that's an interesting story too. So we actually came up, at that time we figured out it cost $11 a month to provide medical and dental care to these kids. Wow.
And so we tried to I was working with the Department of Income Maintenance to get a federal waiver so that we could test a per capita payment system. And we got it all the way to going to DC and meeting with DHS people to be told that they wouldn't fund it because Robert Wood Johnson Foundation would get all the credit. They wouldn't approve the waiver. So that was the most depressing moment of my professional life. It was just sort of like I didn't believe these things could happen. So I was naive. So at that point, the program was still operational. I used all of my sociology background to make sure there was an organizational structure that was sustainable, that the money generated by billing Medicaid would come back into the health program, not into the city's general fund and not into the overall education budget. And that's why it still survives. So then it became time for me to do something else, but I was a little more than a little depressed about all of this. And it was at that point in time I got more involved in medical education, which of course was what my graduate school was really preparing me for. And so I got involved in teaching, in helping coordinate and teaching in the primary care clerkship, which expanded into community-based education programs for the medical school across all 4 years. Again, the emphasis on being, you need to know more than what you see in front of you in a white coat, not in a white coat, in a patient gown, to be more precise.
Yeah.
Or you need it, if you're doing an interview with a patient, it's more than their clinical symptoms. And so it was a very important thing to get medical students out into the community, working with community groups, learning about their perspectives, learning to ask people about their home situation. I remember when we were interviewing patients in the hospital, and they wouldn't ask people what they did for work. And I would say, well, do you think they're a drug dealer or something? I mean, why wouldn't you ask somebody a question like that? But this whole distinction, and then all of the gendered words and judgmental words that get used in medicine. So, someone's a prostitute if they have sex with more than one person, or somebody is promiscuous. I would say that's more what kind of thing would happen. Or women have an incompetent cervix. I mean, so I did everything. The patient denied. The patient didn't deny. The patient said, right? The patient reported. The patient did not deny. And so that was kind of my mission then for quite a while.
And did you have a faculty appointment?
Yes, I was in community medicine at that point.
Okay, all right.
In fact, for that whole time in my primary appointment, from that point on, was in community medicine, which became applied public health sciences.
Right.
So
I found myself wondering from that time, you brought up some terms and phrases I haven't heard in a long time, but I remembered them when you said them. What you think of how things have changed, and maybe how much progress there's been or how much lack of progress there's been. I want to leave it open for how you view it.
I think there's been a lot of progress. I think there's still more progress to be made. And everything I did was about teaching students to think about the patient's perspective as well as what they were learning to do clinically. So we actually matched people with families where someone had a chronic health condition as a first introduction, so that their first introduction to clinical medicine was what patients' experiences were like. And so that was a really important part of what I did. And I did it with the MPH program as well in terms of practicums and coursework. But we still don't understand what people know and believe. Yeah. And we cannot design programs for people without knowing and not judging. Right. I know you are. Yeah. I know you are. And not judging people for what they believe, right, but working with it.
Yeah.
And so in that period of time, so by the mid-'80s, I'd always felt, when I was in graduate school, we had a comparative sociology track, like the medical sociology track, which I always thought was bizarre because all of sociology is comparative, but that was the international group, right? And I could never in my life have done Peace Corps or something else because I couldn't afford to stop moving forward. So I ended up getting involved with Steve in terms of global health, and started working in Haiti in 1988 with a medical student, and then got more deeply involved, and then with Sri Lanka. And so that started my learning about global health and global communities, where these lessons are even clearer because we really don't know what we're talking about.
Yeah.
And the problem is, of course, you think you know more in your own culture, but we don't necessarily know more. And so talking to people and connecting people is always the most important part of it. So that became, I always felt like, using a fairy analogy, that, You go someplace and you learn as much as you ever contribute. And then you can bring some of that back again with the learning. And so it really helped me think about things that we do in other countries and low-income countries that we don't even think about doing in our own low-income populations, in terms of engaging people and getting their involvement in solving problems. So that's kind of, then that part of my work expanded. And so the last part of my full-time work here was really being the director of the global health education programs.
Yeah, that's what I was more familiar with from your story, was your international global health work. So you've been to a lot of countries. Before we started, I was comparing what I think is a lot of travel to yours, which is a lot more. I wonder what do you think about, this is something I've thought about a bit. What do you think about the importance of traveling and seeing other places? I have my own thoughts about that, but this is your interview. So I'm just curious as to how important you think that is. What is it that it changes in someone to see other cultures, other countries, other places?
I think it's really important because I grew up in Iowa. I can assure you that most of the people in Iowa don't know much about the coasts, let alone about the rest of the world. And I've always been interested, but I also always wanted to contribute here first before I got involved in anything else. But it's more the learning. And I have to say, no matter what was going on in the world at the time, what this country was doing to other countries, which we have a history of, people in other countries could distinguish us from our government, even though we're the people who have the most responsibility for our government. It's not a characteristic that Americans have been known for. You know, if you're this, if you're in this country, you're that. Well, it's not true. Not everybody's like that. But more importantly, to come back to the importance of understanding how people view the world. One beautiful example from Haiti is that it's really important when a woman gives birth that she start breastfeeding her child and that the child get colostrum, because that's essential nutrition for the baby. In many parts of the world, that gets thrown out because it's yellow and it's not milk and whatever. And instead, mothers and families give the baby some kind of purgative because they've been in her body and they're obviously full of things that are dirty and not good. But I mean, that's the philosophy basically. And in Haiti, that has been the traditional practice, and it's called lock. And it's a mixture of, I mean, a lot of things that are not sanitary and not good for the baby's intestinal tract. They actually destroy a lot of it. So the breast milk does not. The colostrum helps, clean everything out as well, but it also gives all the nutrition. So the idea was not to tell people that this idea was wrong. They believed it was important to clean the baby out. All right. So colostrum got promoted as the best lock for the baby. So you're not changing this belief. You're just improving the health outcome of it. And it's not diminishing people. Too often, I think we diminish people in the process of trying to educate them. And that's probably the most important lesson I've learned.
Well, I was totally unfamiliar with this story and this thinking, so thank you for that. I find our views of things very well aligned in so many ways. So it's a pleasure hearing your perspective. Unfortunately, we have to keep this fairly short.
Right.
So I want to ask one last question, and I hope this is one that you would appreciate. If there was a younger person who was in our MPH program coming up now, maybe perhaps a woman, and starting out and wondering how to get to a place where they have a meaningful career, what would your advice be, given the path that you have traveled?
Well, that's So first of all, I'm a lot older than I was
Yes,
when I was
right.
a student.
That's why it's a somewhat difficult question.
I have worked with a lot of students. In fact, I just
Yes.
saw one of my favorite students last weekend and her family. And I think you have to be open to what the possibilities are. And you have to take, and I know it's harder now. I think it's a lot harder, not in terms of places for women. That's not the issue. But first of all, with what's going on with the lack of grants and other things, it's a lot harder for people to find meaningful employment, but even opportunities sometimes. Because when all of the agencies that we work with and all the programs that we work with are under tremendous financial stress, they don't have the time and energy to spend with students. But getting out into the community, I mean, finding a good mentor in the program, and we have many now, and then getting out in the community, developing relationships with one program even, and understanding who the people are who come to that program and why they come and what they believe. I think that's a really important foundation because you can always build on that.
Well, I think that's great. I found myself nodding so much. I think I've shaken something loose in my brain listening to you. But thank you, Judy. I think that's a great note to end on. Really appreciate you doing this. And thank you again.
Well, thank you so much.